Hello everyone, welcome back to my channel. This is actually a continuation of the osteology of radius, and today we'll be seeing about the important attachments and applied aspects. So coming to the upper end, we have the head, neck and tuberosity. So the head superior surface is concave for the articulation with the capitulum of the humerus to form the elbow joint. Then the circumference of the head, it is in the form of a disc. Medially, it articulates with the radial notch of ulna to form superior radioulnar joint, and the entire circumference, the remaining circumference, you have the attachment of the annular ligament, which also gets attached to the neck of the radius. So altogether it will be in the form of a cone, the annular shape of the annular ligament. If it is well developed, it will be in the form of a cone, that is the lower part will be constricted and the upper part will be wider. But in case of children below the age of 5 years, we usually say that we should not pull the kids by their hand. The reason is this annular ligament won't be developed and the lower part won't be constricted. They will be almost of the equal breadth. So what happens is when you pull the kid by the hand, this head will easily slip off from the annular ligament. That condition is known as pulled elbow. And it is easily correctable, but you should always be aware of this condition and you should avoid pulling the kids who are of age less than 5 years. Because it is said that after the age of 5 years, this annular ligament will be completely developed. Now, coming to the neck, on the medial aspect, you have quadrate ligament. Then you have the radial tuberosity. The anterior part is smooth and the posterior part is a bit rough. Rough means there is some muscular attachment. So here the muscle attached is biceps brachii on the posterior aspect of the radial tuberosity. And just below the radial tuberosity, you have the oblique cord attached. Now coming to the shaft of the radius, anterior border, we have already mentioned the anterior border. So the anterior border in the upper part, there is an oblique line. So anterior border, the oblique line actually gives attachment to flexor digitorum superficialis. Now coming to the posterior border, thankfully there are no major attachments over the posterior border. Coming to the interosseous border or medial border, as the name implies, it is the interosseous membrane which forms the middle radioulnar joint, because interosseous membrane attaches the radius to the ulna and that forms the middle radioulnar joint, which is a syndesmosis. Now coming to the surfaces of the radius, the anterior surface in the upper part gives attachment to flexor pollicis longus, and in the lower part it gives attachment to pronator quadratus. So you can remember that there are mainly two sets of supinators and pronators, named supinator and pronator. Why I am saying this is there are many other muscles which cause supination and pronation, but two sets of named muscle, one supinator and there are two pronators, pronator teres and pronator quadratus. So in the anterior surface, along with flexor pollicis longus in the upper part, lower part you have pronator quadratus. Now coming to the lateral surface, in the upper part you have supinator, in the middle part you have pronator teres. Now coming to the posterior surface, there are mainly two muscles which belong to the first extensor compartment. I am not talking about the muscles in detail, because once you finish the extensor compartment, then you can remember it easily, like which are the muscles in the first, second, third, like that, because there are mainly 6 extensor compartments, and once you study the contents of the compartment, it will be easy for you. So for the time being, I am just saying posterior surface gives attachment to the muscles of the first extensor compartment, abductor pollicis longus and extensor pollicis brevis for completion's sake. Now we will move on to the lower part. Lower part, actually anterior surface, it is almost flat, and this is the surface against which we feel for the pulsations of the radial artery. Now medial surface, we have already mentioned there is an articular facet which articulates with the head of ulna to form inferior radioulnar joint, and there is also attachment of the articular disc of the inferior radioulnar joint. Now lateral surface and posterior surface, I will deal it together, because again we will go back to the extensor compartment. Lateral surface, we have the tendons of the first extensor compartment related. Then posteriorly, that is the region lateral to the dorsal tubercle. The region lateral to the dorsal tubercle, that is extensor compartment 2, then medial to the dorsal tubercle, extensor compartment 3, and again medial to that, extensor compartment 4. So there are mainly 4 extensor compartments related to the lower end of radius, starting from lateral surface onto the posterior surface. So lateral surface, extensor compartment 1. Now going to the posterior aspect, which is lying again lateral to the dorsal tubercle, that is extensor compartment 2, medial to the dorsal tubercle, extensor compartment 3, and again medially you have the extensor compartment 4. Each components which are there in the extensor compartments we can study later. Okay, now coming to the inferior surface, we have a triangular articular facet. For the first carpal bone, that is from laterally arranged, if you see, the first carpal bone is scaphoid, and medially the quadrangular region is for the lunate. So these are the major attachments of the radius. Now I will talk about some applied aspect. There is one nutrient artery in the anterior aspect. It is in the anterior aspect. If you look carefully, you can see on the anterior surface, just in the upper part, you can see a very small foramina pointing upwards. That is the nutrient artery, which is a branch of the anterior introitious artery. So the code is towards the elbow I go. So from the radius and ulna, the direction of the nutrient artery will be upwards towards the elbow. From the humerus, it will be downwards towards the elbow. So that means it helps to identify the growing end of the bone. So if the nutrient artery is towards the elbow, the opposite end will be the growing end. That is, for radius, it is the lower end which is the growing end. For humerus, towards the elbow means it is directed downwards. So the upper end will be the growing end. That also you have to remember. Now, pulled elbow we have already discussed. Then the next one is fracture. So suppose if you walk and if you fall on outstretched hand, if you fall like this, the fracture will be, of course, in the lower end of radius, say roughly 2 cm away from the styloid process. And what happens is this distal fragment will get fractured. This distal fragment will get fractured and it will project posteriorly and upwards. So altogether, it will be in the form of a dinner fork. Okay, so this pattern is known as dinner fork deformity. Our hand will be like this. So this is known as dinner fork deformity, and this fracture is known as Colles fracture. Suppose if that person is falling with the dorsum of the hand like this, instead of the outstretched hand, if you are falling on the dorsum of the hand, then again you will get a fracture at the lower end of radius, but this distal fragment, instead of pointing posteriorly, it will point anteriorly and upwards. So that fracture is known as Smith's fracture. So Colles fracture, just the opposite, you call it as Smith's fracture. So these are the important applied aspects which you should be remembering while you study the radius. So thank you. Thanks for watching.